Hi, Joe. Excellent talk. Can you speak to the motivation part, especially in the context of that last patient?
Sure.
Specifically, maybe like what you did, what you didn't have to do, and maybe some of the more difficult cases where there's some more work that needs to be done there.
Sure. I think that the biggest thing that you have to do is self-validate that patient that they've made the right decision to come to see you, right? So simply, and I told Eric last night, this is a very strong statement when you tell a patient, you've made the right choice. Okay, when you self-validate that they've made the right choice to come see you. And for this patient, he was very challenging at first to get to open up, especially about his experience. I knew why he was there because the referral said why he was there. But talking to that patient, when I was able to connect with him regarding Ween, okay, that this odd indie rock band, I learned a little bit more about Ween so that I could discuss it with him next time. Again, this might not truly influence other variables, but allows him to trust me as a clinician that I care about his recovery. So that's how I would answer that.
I have a question.
Sure, Jason.
So you mentioned that you didn't just take them up to the gym and put them on TheraBand.
Exactly.
Would you, at some point? How do you integrate this into transitioning into more of a strengthening protocol?
Sure. So I think this has to be an individualized experience, right? So when he's complaining about less pain, when he thinks he's ready, let's try something. I would always attempt active motion first. So you saw in the video that he went through some active ranges. I probably wouldn't introduce other variables, especially ones he had attempted to commit suicide. So I'd probably be very cautious on how I would approach giving him maybe TheraBand or something that he could harm himself with. But at a certain point, we would, when he was ready, introduce more variables into the equation. But again, that's an individualized experience, and I would say that that's more of a gut call in the clinician. I think that we do a great job intuitively in knowing when to introduce something new to the patient. So when he started moving through an active range and said, you know what, I'm ready, the first thing I actually started doing with him was tossing him a balloon. So I would look at his ability to coordinate that motor plan, but in a very controlled fashion. So a balloon is very slow, so he's be able to coordinate the speed of that balloon and take a lot of variables into play, as well as giving a little bit of sensory feedback by having him put his hands on something. So when we did start things, that's what we started with, and then we introduced other things into the equation.
Now we had a question right up here.
Yeah.
Yeah, you talked about like the lighting and things and sort of these, some of these non-specific factors that could be like these, maladaptive inputs.
Yes.
What kind of changes have you made in your clinic or have you recommended, to other places that would make it like less biomedical or less scary, less haunted?
Sure. So I recommend getting rid of all the crap. So do we truly need, as clinicians, again, we're not, I know there's some fitness professionals, so your job's a little bit differently than mine. But when I treat, and I recently wrote about Susan Clinton, she's not here, but she's a clinician in Pittsburgh as well, where her clinic has a couple treatment tables and plants. And it's such a warm, inviting environment. And she achieves, again, you can term outcomes different things, but she achieves great outcomes, and our patients feel good. So I think that clinically getting rid of the junk, potentially if a patient is centrally sensitized, do we need to have the fluorescent lights in the room that we put them in on? Can we get a dimmer light? Or can we get a dimmer put on those lights? So just making those small adjustments in the social atmosphere, I think, can influence their comfort being in your clinic.
We have another question in the back. Check the churches. Do we have more questions queued up?
Question, because I've always thought that patient experience, how you treat them, trumps any of your knowledge base. So I'm wondering, how close do you get to patients where you share a little bit about yourself? Sure. I find that sometimes if you say, I had a child that went through this, but there's also a line you have to have where you don't cross that professional barrier.
Yeah, you're exactly right. So generally, I'm there to listen to the patient, okay? I'm there to listen and self-validate them. With this particular patient, he had a very difficult time communicating and opening up, so that's why I did connect with that music. But I generally don't share much about my personal life unless they're specifically asking for it. So I divulge information if asked, if they truly seem like they desire that information, if that's going to influence their care. But again, we need to listen to our patients, because potentially, if I'm just talking about Asher and Kristen and what I'm doing at home and you know, what I'm doing different places, that could be that input that really, you know, it's annoying at them. It's annoying them. I don't want to listen to him talk anymore. So again, I divulge information if the patient asks.
We had another question way over here on this side of the room. And we're going to have questions from maybe one or two other questions. So we've got another one over here. So we've got 1 and 2, and then if we have time, we might be able to get one more in.
Thanks, Joe. It was a great talk. And again, about non-specific input, do you ever address their home environment and how they could modify that so they're not re-exciting all of these systems when they get away from your nice, soft, well-lit clinic?
You're exactly right. So how many times does a patient leave your clinic and they feel great when they leave, but then they go home and they start hurting again? And we try to, maybe they're not following their home exercise protocol, right? Wrong. So I think that there's potentially variables within the car or at home that we need to take into consideration. Patients with whiplash. When I was finishing up my fellowship training, I spent some time down in Atlanta treating. And I had a patient there who had chronic whiplash. And she would say, I feel great when I come to therapy. I've been coming to this clinic for quite a while, but I leave and I start hurting again. So we moved her clinic to the car. So let's try treating you in the context in which you were initially injured. So in this case, she was parked out in the parking lot. Let's start moving your neck out here and see what happens. And changing that context, she actually started to understand how to move within the car. Context has a lot to do with what happens when the patient goes home. And we need to take that into consideration, guys. And if we can manipulate small variables such as how they move within the car or attempting to modify variables within their home is so important.
Another question that's on the other side of the projector.
Hi, Joe. Thank you very much for your presentation for both your system as well as the case examples. My question is, when you're working with your patients, do you explicitly state the separate stages of the M.I.P. algorithm, or is it all running in the background of your reasoning?
Yeah, it's simply a clinical decision-making model that I utilize before taking the patient through movement activities. So I'm not going to say, all right, are you motivated? Check. You know, did this input work? Check. It's going to be in the back of my mind. And I don't want to say that this algorithm is truly linear, okay? And again, this is all conceptual. It's all theoretical. So I'm suspecting that potentially input could come before motivation or plan. Or I don't know how these fit together, but I know that the three are very important when treating your patients. Okay.
I think we can sneak in just one last question over here.
By the way, yoga session 7 in the morning with Neil.
If you're really hungry, it's Neil's fault.
That's right.
Oh, Joe, I was just wondering, I don't like the idea of laying down and doing a TA.
Yeah.
So I was wondering if you could address that in terms of the potential that actually might change an input in a positive way.
Sure, it could. But I try to take function into the picture. So does this correlate into what the patient wants to do? So if the patient's a dancer, if they're a baseball player, whatever they want to do, I try to have them move within a context. And I try to, clinically what I do, I don't just do exercises, guys. I try to just teach the patient to move. And like Corey was saying, once they kind of reach that edge, you know, let's start to move a little bit past that. Let's see if we can progress that movement. So I generally don't lay them on their back and contract a TA. I would instead probably have them stand and just try to move how they want to move. And when they start to experience pain, let's try to figure out what happened there. So that's generally what I do clinically.
Joe, thank you very much.
Thanks, Jason. Thanks, guys.